Hello and good afternoon. Thank you for joining today's Alliance for Health Policy briefing, Better Health Through Data, Opportunities and Limitations of Health Data. I'm Sarah Dash, President and CEO of the Alliance. And for those who are not familiar with us, welcome. We're a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. You can join today's conversation on Twitter using the hashtag AllHealthLive, and join our community at All Health Policy, as well as on Facebook and LinkedIn. Today's panel is going to have a Q&A section at the end of the hour. We want you all to be active participants, so please do get your questions ready. You should see a dashboard on the right side of your web browser with that little speech bubble icon with a question mark. You can use that to put in your questions at any time. We'll try to get to as many as possible during the broadcast. And if you have any tech issues, go ahead and use that as well, and we'll do our best to help you out. So today's briefing is made possible with generous support from Arnold Ventures, and I would now like to introduce Ariel Mir, who is Vice President of Healthcare at Arnold Ventures, to provide some opening remarks. Ariel, welcome.
Thank you, Sarah. Good afternoon, everyone from DC, and good morning to those coming in from points west. We really appreciate you joining us today for this important conversation, one that is key to advancing health equity in our nation. I'm Ariel Mir, and I'm a vice president on the healthcare team at the Philanthropy Arnold Ventures. And across all our work at Arnold Ventures, we seek to make healthcare in the United States more affordable, higher value, and more equitable. And we know that that goal of health equity is a shared one. The Biden administration has elevated health equity as a flagstone priority since taking office. Through stakeholder engagement, information gathering, rulemaking, and other actions, there's a clear emphasis on addressing health disparities. Across the nation, state Medicaid programs are also prioritizing equity as visible in their innovative waiver programs, managed care procurements, and measurement strategies. And it's encouraging to see so much effort being channeled into understanding and addressing health disparities and to moving towards equity in both health and healthcare. And it's also daunting because offering health equity as a goal is a lot easier than having the will and the means to achieve it. One of the great opportunities and challenges in moving towards health equity is data. They say you can measure what you can measure. They say what you can measure, you can manage. But to do so, researchers and policymakers need to be able to count on the quality, comparability, and completeness of our healthcare data, and also to understand the promise and peril of gathering data and using it in this way. As a funder who partners with researchers to grow the evidence base around effective ways to support individuals with complex care needs, I have just a small window into the challenges that researchers, program administrators, and policymakers face when trying to overlay the context of race, ethnicity, and social needs to administrative data. What I can say is that folks are doing the best they can with what they have, but we decidedly have an opportunity now to do better. And with the stated commitments to health equity so pervasive, it feels like the right time to take bold action to get it right. I'm so grateful to the Alliance for convening today's panel to give you insight into the possibility, the challenges, and some of the steps that policymakers can take to align the will with the moment. Thank you to Sarah and her team, to Elizabeth, Irene, Samantha, and Niall, and I look forward to the conversation.
Thanks so much, Ariel, and thank you to Arnold Ventures for your support of this really important topic. So now I'd like to quickly introduce our fabulous lineup of panelists, and their full bios are included in the webinar materials. First, we will have Samantha Artiga. She serves as Vice President and Director of the Racial Equity and Health Policy Program at Kaiser Family Foundation. Samantha leads Kaiser Family Foundation's work to provide timely and reliable data, information, and policy analysis on health and healthcare disparities affecting people of color and underserved groups and efforts to advance racial equity in health and healthcare. Next, we'll hear from Elizabeth Luukkonen. Elizabeth serves as Deputy Director of State Health Access Data Assistance Center, or SHADAC, which is a health policy research center at the University of Minnesota School of Public Health. Ms. Lucanen currently oversees SHADAC's technical assistance to states in the areas of data use, analysis, and evaluation. And as we'll hear, the states have a very important role to play here. We will also hear from Dr. Irene Donko Mullen, a nationally recognized industry physician and scientist, thought leader, health equity scholar, and author with over 20 years of diverse local, regional, national, and global leadership experience in primary care, healthcare systems, businesses, and community. She's Chief Health Equity Officer and Deputy Chief Health Officer at Meritive, formerly IBM Watson Health, which brings together technologies, data, and analytics. And finally, we'll hear from Niall Brennan, Chief Analytics and Privacy Officer at Clarify Health. Niall leads the company's analytics and informatics strategy. He also leads the Clarify Health Institute, which leverages Clarify's data assets to provide thought leadership and establishes research partnerships with academics and policymakers across the country. And so now I'm really pleased to turn it over to Samantha Artiga to kick it off with some high-level definitions and information on the opportunities and challenges that we face here. Samantha, welcome. Thanks for joining us.
Thanks so much, Sarah, and thank you so much to the Alliance and for Arnold Ventures for having me as part of this really important conversation and sharing this conversation with these great panelists. Next slide. So I just wanted to start with a little bit of an overview of my organization, KFF, or Kaiser Family Foundation. Next slide. We're a nonprofit organization that really focuses on key health issues affecting the nation, as well as the U.S. role in global health policy. Our work spans a range of areas, including policy analysis, polling and survey research, journalism through our media arm, Kaiser Health News, as well as public health information campaigns, including our recent campaign focused on COVID called Greater Than COVID. Within KFF, I direct the Racial Equity and Health Policy Program area, which really focuses on the intersection of racism and discrimination, social and economic inequities, and health. We seek to provide timely and reliable data and analysis of health and healthcare disparities, to increase awareness and understanding of disparities, and to provide analysis of the implications of different policy changes on disparities and efforts to advance health equity. Next slide. So data and comprehensive high quality data is really central to efforts to advance health equity. And this is something that I think has really gained increased attention and awareness over the last few years. We've seen that data is really essential for having a complete picture of the status of disparities, for understanding how different intersectional factors drive disparities, for guiding resources and efforts to advance equity, and then for measuring progress and establishing accountability toward achieving equity, as well as for identifying best practices or strategies to advance equity. And when we lack data or when the data have quality issues, it is much harder to achieve all these goals. Next slide, please. So when we look at key sources of data for health and healthcare disparities, they fall into a range of different buckets. They include survey data, such as federal surveys that are often conducted on an annual basis. Here you see some of the major federal health surveys listed on the slide. We also have surveys that are often conducted at the state level, at the local level, or for example, by private organizations, including here at KFF. Aside from survey data, there is also administrative data. Again, these data are available at the federal level through resources such as the Centers for Disease Control and Prevention, the Centers for Medicare and Medicaid Services, as well as state and local level data. And in addition to these data sources, there are also claims and clinical encounter data. Next slide. So in terms of data on race and ethnicity, there are certain federal minimum standards for reporting race and ethnicity data and collecting these data that have been established by the Office of Management and Budget, but these standards were established a number of years ago. Right now, we see that there are 5 minimum race categories to be collected, which are listed on the slide here, and that there's data collected on Hispanic ethnicity. So these are the minimum standards that then apply to federal surveys and administrative data sets, but there are options for more granular data to be collected when it is supported by sample size. So this is the minimum, although there is additional options to collect more granular data, for example, subgroups within these broader categories. Next slide. So despite these federal minimums, there have been a range of gaps and limitations in the racial and ethnic health data that are available today. These gaps and limitations have existed for a long time, but I think have really been amplified and gained increased attention throughout the COVID-19 pandemic, when really the lack of comprehensive race and ethnicity data was recognized as a hindrance for both understanding disparities and addressing them. Some of the key gaps and limitations I've highlighted here include sometimes the lack of data disaggregated by race ethnicity in some data sets. So some data sets simply don't have race ethnicity data available. When race ethnicity data is available, there often is insufficient data for smaller population groups, particularly American Indian and Alaska Native people, as well as Native Hawaiian and other Pacific Islander people. We often also lack data for subgroups within those broad racial and ethnic categories. So again, those 5 minimum racial categories are very broad, and within them, there's significant diversity of populations who may have very different health and healthcare experiences. We've also seen inconsistency in racial and ethnic classifications. Again, so those federal minimum standards apply to federal data sets, but not to other data sets. And so we sometimes see, for example, across states, a lot of variation in how they both collect and report race ethnicity data. One example would be that some states combine Asian and Pacific Islander people into one group, while other states report them separately. We also see that some states report data using a combined Hispanic or a combined race ethnicity approach, where Hispanic people are reported as Hispanic regardless of their race ethnicity, and other groups are reported as non-Hispanic, where in other cases those data are reported separately. Over time, we've increasingly seen a growing share of people identifying as multiracial or in other racial ethnic categories, which is challenging to analyze and have meaningful data from those, because those categories include a mix of different people. We also have seen a lot of incompleteness in the data, missing or unknown race ethnicity, cases in which those data have not been reported. There also are often lags in data reporting, particularly on the administrative data side. And oftentimes we see that data sets may report multiple demographic factors such as race, ethnicity, and gender, but are not made available in a way to allow for intersectional analysis of those different factors. So for example, looking at how racial and ethnic disparities may vary among people of different age groups. Next slide, please. So I want to give a few examples of what these data gaps and limitations look like in specific data sets. So for example, in the COVID vaccination data at the federal level, over the course of the pandemic, CDC reported COVID-19 vaccinations by race ethnicity at the national level, but did not report those breakouts at the state level, which is really important for understanding different patterns in vaccination, given the variation we know among states. Moreover, race ethnicity data has been missing for roughly a quarter of vaccinations, and there are relatively high shares of vaccinations that have been categorized as multiple or other race. And in those data sets, as I noted on the last slide, the data are not reported in a way that allows for analysis by multiple demographic factors. For example, examining how vaccination uptake has varied among children by race ethnicity. At the state level, some states never reported vaccination by race ethnicity over the course of the pandemic, and now we're seeing that some states are halting or slowing down their reporting. Again, we saw a lot of variation across states in their different categorizations and reporting of racial and ethnic data. Many states did not report data for the smaller population groups, including American Indian, Alaska Native, and Native Hawaiian and other Pacific Islander people. And very few states, again, reported data in a way that allowed for intersectional analysis. Next slide. And I know Elizabeth is going to talk more about the Medicaid administrative data, but just another example of some of the gaps and limitations we see here. Recently, these data have been updated. They provide beneficiary level data for people enrolled in Medicaid and the Children's Health Insurance Program, and include demographic information as well as utilization data. All Medicaid agencies collect self-reported data on race, ethnicity, and language during the enrollment process, but beneficiaries are not required to report it. And you'll hear from Elizabeth some of the variation we see in how those data are collected and reported. There have also been a range of challenges identified with the data, largely around its completeness and quality, which I believe Elizabeth will also provide more details on. Next slide. So really just thinking through, well, what are the implications of these data gaps and limitations? What are some of the real world examples of how they influence our ability to understand and address disparities? So as noted, the lack of intersectional analysis limits our ability to examine racial disparities in COVID vaccination rates for children. We really have very limited and incomplete understanding of health and healthcare experiences for smaller population groups, as well as subgroups within the broader racial ethnic categories. The administrative data that are available through Medicaid continue to be lagged. So I think we will have a lot of challenges identifying who may be losing coverage or experiencing changes in coverage when the public health emergency ends and the Medicaid continuous enrollment provision ends and states begin redetermining coverage for folks. And then also historically, we've had limited insight into how Medicaid managed care quality varies by race and ethnicity. So just some examples of how these data gaps and limitations have real implications for our ability to address and understand disparities. Next slide. Going forward, I think in terms of addressing data gaps and limitations, a few main things to consider. The first is really just the prioritization of data collection and reporting, making sure that it is a stated priority as part of efforts, because that priority often will then mean that resources are focused on those issues. Increasing the availability and accessibility of public data, expanding the data that are available for smaller groups and subpopulations of the broader racial ethnic categories, modernizing data collection and reporting systems and structures to make them more flexible and adaptable to changing collection and reporting needs. And then importantly, engaging community in design and implementation of data collection and reporting standards. So here, making sure that the categories that are available make sense for individuals, as well as then increasing standardization of data reporting to prevent some of the inconsistencies, for example, we see across states in these data, and then conducting outreach and education to providers and individuals about the importance of data collection and reporting, and why reporting these data are actually helpful versus hurtful to help minimize any missing data and make people feel more comfortable and confident in terms of sharing that information to then allow us to have more complete and comprehensive data to understand disparities more broadly. And with that, I'll end, and I look forward to the continuing conversation around these important issues.
Great, thank you so much, Samantha. That was an amazing overview and really great tee up to Elizabeth to dig into what's going on at the state level. So Elizabeth Luukkonen, welcome. Thanks for joining us from Minnesota, and off to you.
Thank you, Sarah, and just thank you to the Alliance and to Arnold Ventures for hosting this event. I'm really excited to be included on this panel, and super happy that Samantha went first because she provided such a great overview of the various data sources that can be used to examine and improve health equity, and gave some really concrete examples of why it's so important. Now, I'm going to focus on a specific data set. So next slide, please. And that is Medicaid administrative data. Next slide. And Samantha alluded to the fact that these are data that are collected through the enrollment process typically and are self-reported. And we have been working really hard with states to improve the quality of these data, and what we've come up with are a variety of reasons for why the data quality here is poor, and primarily it's related to missing data. And the data are missing for several reasons, and some of them are, tied to what Samantha said. So the guidance from the federal government is simply not consistent with the most recent evidence on how these data are best collected. So Census does great work on, thinking about how to ask people questions about race, ethnicity. They have found that asking one question, a combined race and ethnicity question, is really the best way, and also offering additional ethnicity options such as Middle Eastern or North Africa, and doing that will really decrease non-response and improve accuracy. But the guidance, unfortunately, still recommends a 2-question series with only Hispanic as a race option. The other thing is that this is voluntary. You cannot compel people to report race as a condition of their eligibility. So when states are processing applications, this has to be marked as a non-mandatory question. The other issue that we found working with states is question design, so both wording, but also response options. A lot of states simply have questions that don't have response options that resonate with the communities that are answering these questions. And if you don't feel like your race or ethnicity is represented in that long list, you might just skip it. And then finally, probably the most important is that, and Samantha just closed with this, is the trust. People are concerned about how the data will be used. Next slide, please. And all of this leads to quality problems. And this map shows, wait to see the map, there we go. This map just gives an overview of the quality of the Medicaid administrative data related to race. CMS does an excellent job of assessing data quality with Mathematica's support. And this just shows there are 4 states right now that have unusable data according to this assessment, and a large handful where it's really unusable. So what a lot of states are doing, and I would say almost every state we've ever talked to, is really committed to improving their race ethnicity data in Medicaid, is we work with them to try to make these data better. And the first question we always get from states is, what are other states doing? So next slide, please. One of the first things that we did at SHADAC is to just do a scan across the states of how these questions are being asked. So we scanned both paper and online applications and found there's a fair amount of variety, but there are some similarities. The first thing is the majority of states, when they ask their Medicaid enrollees about their race and ethnicity, they have 2 separate questions. So not aligned with the best evidence on how to ask, but aligned with federal guidance, which is maybe not surprising. Then across the states, we did notice that there's a huge variation in the type of response options that are offered. So 62 variations across these paper and online applications, which in many states often actually differs. And you'll see there on the right-hand side of the slide, a chart that shows the number of response options by state. So the horizontal axis is number of states, and the vertical are the number of response options. And you can see states cluster around, having 5 or 6, which is, aligns with the standard OMB categories. And then there's also some clustering around 15 and 16 race response options, and that's consistent with the HHS standards in the model application for Medicaid developed by CMS. It's really important to note that only 3 states, Maryland, Oregon, and Vermont, actually offer alternative race option or ethnicity options such as Middle Eastern, North African, etc. Next slide, please. So as we have been working with states to try to think about how to improve these data, we've come up with 2 streams of activities. One is to enhance the existing data that they have. So we know there's a lot of missing data, but what can they do with the data that they have to try to improve it? And the first thing that we've been working with states to do is to leverage other data that they might have available to them to sort of triangulate the data within the Medicaid program. So this often means identifying individuals in other data systems they have access to. So example, if a person is enrolled in another public program, or providers or managed care organizations that work with Medicaid, if they have race ethnicity data, and pulling that data from those other systems. The second is more of a statistical methodology where you're filling gaps in your data using other information about the individual. So if my data were missing, it would look at my surname and maybe where I live and try to give some indication of what my race might be. And you can imagine there are concerns with this methodology, but it is one way that states can use to fill in some of the gaps. And then finally, we always recommend that states validate their data against other sources of data on race, ethnicity, and probably the best source is census data from the American Community Survey, huge survey that asks people about their race, ethnicity. The state can go to that data source and look at the distribution of race, ethnicity in their state and see if it comports with the data that they have within Medicaid. So it might be that they have a lot of missing data, but it could be that the distribution of the data that they have is pretty accurate. On the flip side, often it's that they're missing specific race and ethnicity categories. So for example, they know that they have many fewer responses for Hispanic enrollees, for example, than looks like is reflected in their state. And that tells them they have a specific problem with maybe a specific group. Admittedly, states tend to focus here because it's easier than some of the other tactics that I'm going to talk about, and it doesn't conflict with the guidance that's out there. Next slide. So the second stream of things that states often do to improve their data really has to do with improving the quality of the data that they're actually getting and the response rate. And the first one on this list is really, really effective, and a lot of states are starting to do this. And this is to make the response to this question mandatory. So as I said, you can't require people provide race ethnicity data as a condition of their eligibility, enrollment, but you can say, look, you can't skip the question on your online form. So basically you're doing a forced response, but that response can be declined to answer or unknown. And this just really compels people often to say something, and I'll give you some data about this in a little bit. The other option that some states are choosing is to improve the question format, and this is happening slowly, but I think a lot of states, more states are starting to think about this option. So it's going from that two question, what is your race, what is your ethnicity, to a combined question that lists all of those in one single question. It's just easier for people, it resonates more. And then also improving the response option so that they better match the population that's actually responding to these questions. The final three are hardest. They're also, in my opinion, the most important. It's sort of the long game, if you will. And this is to engage enrollees and stakeholders, figure out why data aren't being provided, and figure out how to improve data collection through better response options, better question design, better instructional language. And I think really, really important is engaging the type of people who are helping people to enroll in Medicaid. When we talk to navigators and enrollment assisters, they're telling people to skip this question simply to get through the application. And I think once they understand how critical these data are to the improvement of health equity and to health equity programs and reporting, then they change their tune and they start encouraging people, or at least informing people on why they might want to answer it. And then finally, there are some post-eligibility activities. So once people have enrolled in Medicaid, prompting them for missing data every time they log in or when they are at renewal. And I do think that states are starting to consider these activities more and more. Next slide, please. So I'm just going to talk about 3 states who have all of whom have done a lot of work to improve their race ethnicity data. And the first is Oregon. Oregon has sort of the perfect question, if you will. It's a single question. It has a lot of different response options that align with the communities that they serve. They have a question about assigning primary race. And it's easy just to think, oh, great, they did this and they got buy-in and got it on their, this is the paper copy, but it, matches similarly to their online version. But this was a result of a lot of work that started all the way back in 2014. They have assessed the question, improved, done a ton of community-based engagement and education, and incredibly important, they've monitored the results of these efforts and have seen a decline in missing data. And I should note, I'm focusing on race and ethnicity today, but Oregon is also doing this around the collection of sexual orientation and gender identity, disability, language. I mean, they're just really, really committed to improving their demographic data. Next slide, please. The next is, see if it pops up. Next slide, please.
We're having a little bit of a lag, so apologies.
Oh, sure. I'll just go ahead and talk about it. So New York did something a little bit more involved. They did a pilot program. They basically focused on educating enrollees on why their data are being used through better instructional language. They also trained navigators and assisters, and then also made the response to the question mandatory, which I talked about before. And they have also evaluated this pilot, and they found that their response rate grew by 20 percentage points. So that's a big deal. And they're gonna roll this approach out to all of their enrollees and assisters and similarly evaluate it. Next slide, please. And the last state I wanted to highlight is Maryland. Maryland is using American Community Survey data, so data from the census, and what they really wanted to do, they knew they didn't have energy to do a ton of work on this right now, but they wanted to improve their question. So they looked at data from the census to try to get a sense for the racial and ethnic groups and non-English language clusters in their state to beef up their response options. They also talked to state staff and other experts who have a strong understanding of the relevant communities, and they came up with a revised list, increasing the response options from 15 to 57. Next slide, please. And I should note they're planning to evaluate the impact of that moving forward. So I just want to close with, you know, I'm a data person, so I always feel a little weird talking about this, but I do think in this case, the data quality is really just about trust. At the end of the day, we're asking people for personal information about their histories and lives and their identity. And, you know, we need trust and good communication to get them to respond. And this means community input needs to shape the questions and the response options, and individuals need to know how the information is going to be used. And this is just kind of an example of that. You know, some states will just ask, what is your race? And then you have other states that really, even in small spaces, try to communicate how important the information and how it's being used to build that trust. So the last slide is just some resources I thought might be of interest. This work that I do is supported by the State Health and Value Strategies Program. They have a wonderful website with a, you know, sort of one-stop shop information that I encourage you to check out. And thank you. With that, I will turn it back over.
Great. Thank you so much, Elizabeth, for that really super helpful, detailed presentation, and for giving us some examples of best practices. And I would love to get into some of those a little bit more in the Q&A. So now I'd like to invite Dr. Irene Donko Mullen. Hello, thank you for joining us, and take it away.
Yes, thank you. Thank you also for the opportunity to be on this panel. I'm delighted to be here, and I appreciate the invitation to discuss and share perspective on this topic, and to be part of these excellent speakers and experts on this topic. So what I'm going to do is to build on the previous talk on data, and mine will focus on opportunities for better health through big data, right? So the types of data that we leverage in health tech industry and aligned with the AI and machine learning. Next slide, please. So just a little briefly, I serve as Chief Health Equity Officer and Deputy Chief Health Officer at Meritive, and Meritive is a data analytics and technology partner for the health industry. Basically, we support the healthcare industry and clients who provide health and human services. And what we're doing at Meritive is an extension of our work that we were doing at IBM Watson Health. So same mission, and we realize our need is even greater, right, given the ongoing effects of the pandemic and the global recession and overall the economic hardships that are facing a lot of communities now. Next slide, please. Just a little bit. So in my role, I do promote efforts such as building inclusive technologies, promoting inclusive data, right? Figuring out how we can ensure data diversity, completeness, comprehensiveness, ethical AI and machine learning, really with principles of fairness and trust and transparency. So often thinking about how we can design better solutions in health IT for health equity. And the populations we serve, the patients and the entire health ecosystem. And we often think about bias in our machine learning algorithms, and these are some of our commitments and work that we are doing to promote better data, better analytics, fair and just AI and machine learning technologies as a strategic lever to make healthcare more efficient, more equitable, and to surface more intelligent insights for decision making. Next slide, just wanted to share some examples just to provide context for the data sets that I'm building on. And we know in recent years, AI and machine learning systems have been integrated into our public health systems, our workplaces and homes. And rightly, we are increasingly concerned about the social, economic, and ethical implications of these tools, and concerned about the data and digital divide, right? And what kinds of data is being leveraged for these technologies and how it impacts health, how it impacts outcomes and disparities. And these are some of the applications of AI in preclinical research in population health, just a few examples. We can go on to the next slide because I wanted to get to the core of my talk, but as I mentioned earlier about how we work with clients to design better solutions for health IT that will ultimately lead to improved health outcomes. And as part of this, we also really think about how we can mitigate AI bias, and it's all around the data. And just quickly, most of the time when we talk about AI and machine learning or data for that, we often refer to that AI system that has been designed, how the data is used in training and testing. And even though bias can be present both in the model of the algorithm or in the data set that's used to train it, it really emerges more broadly than this. It can emerge because of cultural or social or institutional limitations or the technical limitations of the design. And so on the next slide, I want to spend a little bit more time talking about the broad aspects of data and bias and how that impacts health equity. Because we all know that data is transforming our lives in a lot of ways, in every part of our world, because we use these data to make decisions in so many ways in the healthcare space, in public health with states. And data is being leveraged, right, to allocate resources, to target interventions, to identify populations that are at risk, and so much more. And so I usually think about there are three different sources of data to inform and advance progress in achieving health equity. One is the research, right? Research data that informs evidence. One is so that's clinical trials, research studies. There's also real world evidence data that we pull from EHR and clinical encounter data, the health surveys. So this is what Samantha and Elizabeth talked about, health surveys, interviews, and now we have data that also comes from social media networks. But on this slide, I've expanded sort of the general concepts of data biases that feeds into our AI or clinical decision support. And one is the research or science evidence. So we have a science or clinical evidence data bias stemming from how we translate science into care for our populations, for our patients, especially our communities. And decision making is informed by a synthesis of evidence that's tied to clinical trials. It's tied to randomized controlled trials. And so if these studies or trials or practice-based guidelines are not diverse or inclusive, then we run the risk of building unreliable models with biased science evidence base. There's also the provider bias, right, where a healthcare provider experience or expertise is an integral part of translating science data or health data into evidence or into improved health outcomes. And I talk a little bit about that as well. Exclusion of data has been mentioned by our previous speakers about the lack of diversity in data, the lack of standards, including appropriate categories of race and ethnicity, or gender identity, or disability status, or occupation, and the range of all those social determinants of health that we know have been linked to disparities or discrimination from getting quality health care. And so our data information or architecture may not fully capture that science evidence that we know have accumulated around health equity. And, I think Samantha mentioned, and Elizabeth, that sometimes our current practices reinforms norms of homogeneity within Black communities or Hispanic communities, Indigenous, but we know that they're within group differences or population group differences, or different features or risk attributes that may contribute to their outcomes or their risk or resilience. And then the fourth aspect of data bias is how we're missing the influence of environmental, occupational, workplace exposure, life course exposures on health outcomes, right? So this all includes access to resources and opportunities for optimal health. And the fifth aspect is data empathy, which I call data empathy because it refers to how much empathy or patient values or preferences or patient reported outcomes and data are integrated into our care or decision making, into our measures, into our benchmarking efforts for health equity. And so data empathy includes that knowledge or experience about the people or the places or the factors that actually make up the data. And lack of knowledge of those data sources or an inability to recognize those bias results in our inability to optimize algorithms or models that go into the decision-making process. And so I think the next slide finally just wanted to share, the next slide please, the informatics or social determinants and informatics challenges. It's around disparate data or data collection, and the fact that our data is already disparate or inconsistent or largely incomplete. In terms of data curation, we know there are issues with the definition, the granularity or context for social determinants of health data. And so, for example, you may be looking at housing instability, but there could be homelessness, there could be unsheltered or sheltered homes, living in transitional housing or substandard housing. And so all these level of or homelessness will require different kinds of interventions, right? And so there's all that needs to be standardized, as well as the choice of data. And there's value we know in adding different analytics or in our predictive and risk models. And I think I'll go to the last slide, which our goal, so as we're thinking about data, our goal is around ethical data as well, or ethical AI. And we're currently, it's still a work in progress. The goal is really to optimize not just data, but our AI and machine learning's beneficial impact while mitigating risk, while mitigating the adverse outcomes for all populations, for stakeholders and doing it in a way that promotes human agency and allows us to all populations to achieve their optimal health. And so I think this is my last slide, but I think what wanted to mention is that, determinants of health, causes of disease are complex. They're dependent on multiple biological, environmental, and social, cultural, or economic factors. And so our efforts at looking at data and bringing technology or advanced analytics really need to be able to sufficiently address the complexity of determinants of health. So thank you for listening, and I will turn it back to you.
Thank you. Thank you so much, Irene. Wow, what an amazing, amazing presentation on the sort of the future is now with AI. And we really can't think about it without thinking about health equity. So now, Niall, would love to hear your thoughts as Chief Analytics Privacy Officer at Clarify Health. Help us understand kind of how your company is thinking about these issues and kind of the, if you would, kind of more of the private sector writ large, and talk through the privacy issues as well. So off to you. Thanks.
Yeah, absolutely. Thank you, Sarah, for having me, and thank you to all the other wonderful panelists. You've certainly saved the worst until last for this webinar. And I don't have slides. I'm going to sort of speak contemporaneously and in part give some of my own thoughts on this, but also reflect on many of the excellent comments that the previous panelists have gone through in great detail. So, obviously, I think this focus, or really strong focus on addressing health equity is long overdue and very much welcome. But as the previous panelists have alluded to, it can be pretty hard. The aspirations of where we want to go is kind of running smack into brick wall, no pun intended, of reality. And as a data person and a data nerd, it's both personally and professionally very frustrating not to have that information. Although I think both in the public and private sectors, a lot of people are doing a lot of really great things to try and improve the information. But this is, it's just fundamentally difficult. It's hard. And I think one of the reasons is that our data collection mechanisms aren't really optimized for this type of data. We kind of have two extremes. We have a relatively let's just say universal claims and administrative data infrastructure. Many of those were designed 20, 30, 40, 50 years ago and weren't necessarily at the time. Maybe the collection of this information wasn't considered important, or it wasn't prioritized. And then we've got this massive, rapidly evolving, emerging set of more, modern data systems, all our investments in clinical health records and all the work that folks at Meritive and companies like mine are doing, but they can, electronic health record data, while there's been incredible progress, it's, huge rate limiting factor is both an inability for the data to be, truly interoperable and flow, and also, to a certain extent, almost too much data in electronic health records, and sort of separating the wheat from the chaff and figuring out what's important. And I think another reason why it's hard, and I think just about every panelist mentioned this, and I'm going to double down on it, is trust. So I think a lot of people are unsure or afraid of how this information might be used, even if people's intentions are are really pure around this, and I believe that they are. It gets to Ariel's point, you can't change what you can't measure, but a lot of the folks that we are trying to capture this more granular information on are people who have been repeatedly let down over many generations by the healthcare system and by society in general. So I think when you start to make these well-intentioned efforts to try and harvest the information, you can run into some resistance because people are not sure of how it's going to be used, and the whole conversation about artificial intelligence, and we know that there has been embedded racial bias in a lot of artificial medicine projects to date. The community is aware of it, is working really hard to try and reverse and control for that trend, but all that filters through to the common person on the street, and I think that they they can view some of these efforts with mistrust. And I'm going to a little later in my comments, I'll loop back to this trust issue. Again, I think the other challenge is letting the perfect be the enemy of the good, and I think we have to maybe reluctantly acknowledge that we'll never get to truly comprehensive race, ethnicity information at the sort of health insurance claim level for the entire population. So we have to decide, like, what is good enough and when is good enough. Is it 40 or 50 or 60%? And people, I think, have also been very creative then in acknowledging these limitations and using taking more geographic approaches. The social vulnerability index, the area resource file, and other types of geocoding that try to infer a certain set of characteristics to different populations depending on where they live. Now, obviously, you lose a little micro level precision, but you expand the sort of the lens that you can take to these problems and look at these things more comprehensively nationwide. I think the chart on the sort of TMSIS readiness or data validity as it pertains to race, ethnicity was both fascinating and quite sobering. And so we didn't really talk about Medicare data much so far today, and we didn't talk much about commercial data on the Medicare side. On the one hand, there is race information on Medicare claims. On the other hand, Medicare gets it from the Social Security Administration, and it's widely acknowledged to be inaccurate and result in a pretty fundamental and significant undercount of Hispanic people, and that doesn't even get into the more granular categories that were discussed by others on this call. So, CMS over a period of about 10 years worked really hard to layer in some analytic and geocoding approaches to try and adjust the race ethnicity information that they had in order to improve those estimates, working with RAND Corporation and the like. On the commercial side, I think a lot of payers have tried for a really long time to get this information, and they're running into the same barriers that state Medicaid agencies are. People don't really want to change. I know in particular, Aetna tried really, really hard to do this over a multi-year period, probably spent a lot of money, and I can't remember the exact numbers, but I think they might have stalled out at around 40 or 50% coverage or accuracy. And addressing equity, while race ethnicity information is obviously really important, I think addressing health equity goes way beyond capturing race ethnicity information. And so I think there are a lot of efforts in that area too, food and housing insecurity, et cetera, et cetera. One thing that has particularly fascinated and again frustrated me as a data person has been that we've had a whole series of Z codes that can capture this information and can be coded on claims for about the last 5 years. And if it doesn't matter if you look at Medicare claims, Medicaid claims, or commercial claims, we are systematically failing to capture that data on claims. So it's potentially new information can flow into this existing data collection infrastructure. And why are we not collecting it? We're not collecting it because providers aren't incentivized to code that type of information. And so study after study after study shows that you sort of only code what you think you will be paid for. And so I know CMS are taking this very seriously. And just to sort of put it in hard numbers, Z codes are only being coded about 1% of the time in claims data, maybe a little closer to 2 in certain circumstances. And so I think we can do much better there. As Ariel alluded to at the beginning of the call, in general, health equity is a huge priority for the Biden administration. CMS, in a recent payment rule, asked for people's input on the appropriateness of Z codes to collect this information. And of course, they're also introducing new screening tools and requiring hospitals to fill out health equity surveys and the like. So in terms of the private sector, then I think there's a lot of organizations like Clarify and others who are trying really hard to bring additional lenses to the data that we work with to try and shine a light on health equity. It's a massive priority for just about everybody we work with, certainly every health system that we work with. And so, there is information out there that is, generated as a, byproduct of consumer interactions and different things like that. And so that information can potentially be useful. But I think, again, it's another area where we have to really proceed with caution, right? You don't necessarily know that certain consumer data about you, even though it's probably buried in the fine print when you swipe your credit card, that certain consumer information about you could eventually be used to inform how a provider might treat you. And again, I'm not saying that the motives are bad, but you do get into some, I think, interesting, almost ethical territory. And again, it gets back to the trust issue. Maybe there are things that people don't want their doctors to know about them and didn't expect, and are shocked or annoyed, or that a doctor knows something about them from their past that they've inferred from a different data source, no matter how well intentioned that effort may be. So I think that's the end of my comments, and I'd like to thank Sarah again and all the other fantastic panelists, and I'm sure we'd be delighted to answer questions.
Great. Thank you so much, Niall. And so let me invite everybody to come back on camera so we can answer questions. There's already been some really great questions coming in from our audience. And so I am really excited to have a really robust discussion. First, I think, you know, there's I think in the resources that you should have on your website, there should be an infographic from CMS about Z codes. And so for those of folks who are interested in learning more. But I mean, to your point, Niall, like there's a lot of really sensitive information here, like Z59, problems related to housing and economic circumstances, Z60, problems related to social environment, Z62, problems related to upbringing. So I mean, like, how does a clinician, and I'll let you start then let others kind of answer. I mean, like, how do you even begin to like assess the needs that somebody may have like within the course of a standard medical encounter to like even begin to apply kind of those codes around sort of social determinants of health and be able to use them? I know that goes obviously beyond certainly race, ethnicity, gender data, but like I'm curious, and maybe Dr. Donko Mullen too, from your perspective as a clinician, like how does this actually get implemented?
Yeah, I think it's definitely challenging. I think, you know, some of the codes, you know, maybe more straightforward than other. I mean, if you're seeing, you know, a homeless person at the emergency department for the seventh time this month, you know, that's pretty straightforward. But you know, other things, you know, actually get, you know, a little bit subjective, and then it gets back to the trust thing. You know, how dare you suggest, you know, this or that or the other? It's another layer of complication with, you know, children engaging, you know, in medical care with guardians there as well. So, and in many respects, it also, you know, places a spotlight on how physicians interact with patients and the time they're given to do so, and again the incentives they have to try and dig into to understand these problems, because a lot of the time, you know, the physician is just treating, you know, what the clinical reason is in front of them, and doesn't have the time or the incentive to perhaps dig a little deeper and figure out what's driving that clinical condition.
Yeah, that's really helpful. And Dr. Donko, I want to ask you a kind of related question, but before I do, I need to do a mea culpa. I think earlier I said we had an hour. We actually have an hour and a half. So for those that need to move on to their afternoon meetings, definitely still catch up with our recording at allhealthpolicy.org. And for those who can stay, please do stick with us because we've got a lot left to talk about. So Dr. Donko Mullen, Irene, like, are you worried that, you know, you talked a lot about racial bias and provider bias, you know, like, are you worried that someone might kind of mistakenly infer like certain things about a person's life based on their race? Like, how do you start to like acknowledge and deal with that, and so that like from the very source of like, you know, coding this data or putting it in someone's medical record, it's correct and accurately captures the person's life? I know that's like an impossible question, but just I'm going to that clinician patient encounter like from the get-go. Like, how do we start to deal with that?
Yeah, I mean, that's a great question, and I think that's where a lot of work needs to be done. We all know, right, that health outcomes or a patient or a person's health is influenced largely by their social determinants of health, by environmental determinants. And so as a provider or as a physician or a clinician, it's really important that when you're dealing with patients, you know, in addition to race and ethnicity, that you have a thorough understanding of their culture, their belief, their life experiences, because that's what helps, I mean, in terms of clinical decision making. I talked about, you know, a large part of provider bias is what, you know, feeds into our EHR, it feeds into, and claims data, because, when a patient comes into a provider or clinician's office, a physician needs to listen to their story and understand their preferences, and examine the patient, combine all the labs and imaging data. But I think a lot of the time, sometimes there are inherent stereotypes, I would say, or biases that stem from either their experiences dealing with similar patients or societal influence, that, and their action can be influenced by that, right? But we really want, a provider's action to be influenced by their compassion or their sense that, there are larger determinants of health that they need to address. And so you don't really sometimes often need to, really get, I think part of what I'm trying to say is humanity and empathy and compassion are all aspects of patient-centered care, and they're important for addressing disparities and for treating patients. And it's really important to even get a sense of an individual. I mean, I think Samantha or Elizabeth talked about the fact that there is that intersectionality that we often don't measure. But it's, like Neil said, Neil was talking about the fact that it's only 1 or 2% of social needs that are captured in C codes, and it's totally, to me, I also get upset about that, because it limits, how we treat patients. But it's tough. I mean, I think it's a good question, and I think we need to work on that. A large part of our data limitation is from those biases and not having that data.
Yeah, thank you so much for that insight and response. And we actually have a lot of really great questions in here. Some of them about that question around intersectionality. How granular do we need to get on data? So and the role of states. So I'm going to pitch some of those to you all in a moment. Again, please, folks, keep those questions coming in. So Samantha, let me kind of turn to you on a couple of those questions. I mean, is there consensus, on how granular we need to get in terms of race and ethnicity data to capture subgroups? Like this was a question that came in from the audience. Is it 5 additional, 10? Like, what's the most effective way to better capture, those subgroups? I mean, I think you made a really clear case that we're definitely not doing a good enough job of really encompassing all of those. But can you speak to that a little bit more? Like, how granular does one need to get? And then I'd love to get to a question about that intersectionality that was raised.
Sure. I mean, I don't think there's a standard answer here. In part, it's going to depend on what question you're asking and the data set you're using to answer that question. I think at a broad level, we know that there has been an ongoing issue with really incomplete or small data sets available for the smaller population groups, in particular American Indian and Alaska Native and Native Hawaiian and other Pacific Islander people. So I think thinking about ways to increase the data that are available to understand the experiences of those population groups is particularly important. At the same time, when we look at disparities using these broad racial ethnic categories, that the 5 groups and the 1 Hispanic ethnicity that are recommended by OMB, if you look across a broad array of measures of health status and healthcare access, for example, you'll see that Asian people tend to fare similarly or in some cases better compared to their white peers. But that can often mask real underlying disparities among subgroups of that population, where there may be very stark disparities in health and healthcare access that are important to address, but you can't see that without having that subgroup data. So just highlighting where having some of that more nuanced data is important. I think The issue that you will begin to run into, particularly, and Elizabeth can maybe speak to some of this more as well, is when you get into state level data or local level data where you have smaller overall numbers of people, you start to run into data privacy concerns, because if you cut the data too finely, then you start running into those as potential issues. So there is this balance against data privacy, but still wanting to really have a comprehensive and complete understanding of the diverse experiences of people within these broader categories. And then Elizabeth, I don't know if you have more you would add on that.
Yeah, I mean, I think you summed it up well, Samantha. The only other issue I'd raise is the practical one, which is, you know, Oregon has 37 response options, but they also have incredibly sophisticated analytics staff. You could collect write-in data for everyone so they could completely personalize their response, but you have to process those data, and Medicaid agencies in particular do not have the kind of staff, and I don't even think private industry does either. So, you know, I love the idea of not letting the perfect be the enemy of the good, and I would just take that even further and say actual people have to process these data, so though you have to take those considerations into account when you're thinking about collecting granular data.
And I would just add that from an industry, or when you're dealing with AI and machine learning, sometimes we need that robust granularity, especially when you're building predictive models or risk stratification models. That because it may make the outcomes more accurate, but closer to being accurate, not accurate, I would say. So sometimes we need to capture sort of the complete race, ethnicity, or exposures, in addition to, I mean, this is where intersectionality is important, especially when you're developing these predictive models, because we know a lot of populations have more socioeconomic variability, which may contribute to their health status, and it's not just simply looking at race and ethnicity or socioeconomic status.
Yeah, thank you for that. And there was a question, kind of wonky question from the audience around whether anyone on the panel could further describe sort of current data, methodological, and statistical challenges that are involved in taking an intersectional approach. So again, right, like and maybe someone can define intersectionality just for the sake of making sure that that we have a definition here. But can you provide some suggestions, some studies to sort of advance that field of data science? So, you know, maybe you could give a brief answer and then maybe point us to some additional resources there. Irene, would you like to get us started and around the data methodology?
Yeah, I could try. So there's a lot of like engineering, right? Feature engineering that goes into it, and predictive modeling. And in terms of when we talk about intersectionality, it means, you know, for example, a person may not just have, you know, race and ethnicity may contribute to their health outcomes, but there's also the social environment. There's, you know, they may also have, you know, we can think about we have it ability, you know, different sexual orientation and all that. So there may be the combination of different demographics that may contribute to the outcome. And how do you determine those relevant determinants that contribute to the health? And this is what a lot of, I mean, there are smart data scientists and machine learning you know, scientists that look at those variables and those features and put weights or make combinations in what, you know, feature engineering and different causal inferences, patient similarity models. There are different kinds of methods that they may combine depending on the research question that they're asking. And so, for example, if they're saying, what is my patient risk of developing a certain disease? They may have to look at a lot of data, right, which has, you know, that disease progression, race, ethnicity, age, location and time, and other comorbidities. to be able to rightly compute, an estimation of their risk of developing a disease. And so it all depends on the research question as well. So I don't know if I sort of gave an answer, but that's
Thank you. No, that's great. We will need a whole nother seminar just to dive into the methodologies. And obviously, with 15 minutes left, we have to kind of focus around the policy impacts. I do want to ask, because there have been a couple of questions that have come in and kind of turn this to the state level as well. But we have had a couple of questions come in about the difficulties or lack thereof for collecting data on sexual orientation, gender identity, or so-called SOGI data. Elizabeth, I think you alluded to this. Like, can you speak to that, like at the state level? Like, what is the status of that? What efforts may or may not be underway? And can you speak to the importance of that?
Yeah, absolutely. So we have done a similar scan to sexual orientation and gender identity questions that we did for, assessing race. A handful of states do collect this information as part of Medicaid applications. They might be doing it in other ways. And I think the challenge here is that there is much less consensus on how to ask these questions in a sensitive way, in part because the language changes. It really depends on the age of the participant or the respondent, for example. And so, this is an area where some federal commissions under the Obama administration did some really excellent research, but now it's old. So we probably need a little bit more work, but there are some states, I'll point again to Oregon, who's doing some great work on this. And here, I think almost more importantly than race ethnicity, you have to talk to your communities and figure out what language resonates, how to ask the question in a socially appropriate way, what age you should ask, and then really, really critical, this is a question where you have to ask people more than once. It's not like a birth date, because identity in this area changes over time sometimes, especially when you're looking at, throughout the life cycle. So one of the things we've been talking to states about is how often do you ask it? When do you overwrite data? They're pretty complicated and challenging questions, but hugely important, to state policy.
Yeah, thanks. And just a quick add on to that, because this came in just now. And are there any federal standards right now, or guidelines, or anything along those lines right now?
The only guidance right now that is, associated with the race guidance is sex, and it's, male, female. So it's definitely with the promise of an update, but that promise is pretty old. So I would say largely no.
All right. Okay, so many questions, you guys. And I want to, by the way, give you all the opportunity to ask one another question. So let me actually pause and just do that. Like, are there questions that you have come up with as you've been listening to one another that you're like dying to know? I'll give you a chance to think about it. Niall, let me ask you a question that came in while you all are thinking about that. Someone can ask sort of what can employers do to push their carriers or administrators around race ethnicity data? What can very large employers do with the claims data for their population? Do you have any insights on that?
That's a whole other ball of wax. I think it's an important issue, but candidly, I think for employers, they're probably not super focused on it. I'm not saying they shouldn't be, but they're so busy being, I think, just like crushed by healthcare costs in general. And so one of the things that has fascinated and frustrated me over the past 5 years or so is why aren't employers pushing their TPAs along a whole range of issues that could include this. And, I think that they're just sort of overwhelmed, and they're sort of just solving a math problem. Like, what is the combination of overall benefit decrease and overall premium increase that will not, cause me to, lose employees. So I do hope, I mean, there's folks like Elizabeth Mitchell at the Purchaser Business Group on Health, who's like, really leaning into these problems, and others in a very aggressive way. So hopefully employers will begin to, make more demands along those lines.
Great, great. So we have about 10 minutes left, so I want to make sure to ask some kind of cross-cutting and overarching questions. One, I want to turn to Elizabeth. You shared 3 great examples of some best practices, and you delved into a little bit of the the incredible behind the scenes work that went into developing those best practices. So in your experience, and that was 3 states, right? Like how quickly can states adopt one of those best practices? Like, what does it take, in the absence of updated federal guidelines? And then I want to ask Samantha, then, what are the prospects of then aligning federal guidelines with better evidence and best practices? So Elizabeth, just start us off from the state level. What does it take?
Sure. And I hate speaking for states, but based on the ones I've talked to, I would say first and foremost, nobody likes to get ahead of the federal government. And we have definitely worked with states who have gotten ahead and then been pushed back for one reason or another. A good example is if you have a combined application for health and food stamps, for example, food has a very specific way they want you to ask the question, and if you disagree, then they had to kind of go back to the drawing board. So first, I would just say that is a real and true barrier to moving forward. I think there are some small things and some big things. Some small things that states can do are, typically it's not super hard to change response options, but it can be getting in the IT queue for example, make it mandatory. So to me, I was like, yeah, just make it, make it a mandatory question. And they sort of look at you like, get in line, with the million other changes that have to go in, So I think that it is not as easy as it seems, but I will just close by saying there's high motivation. Every state wants to get their data better. And so they're pretty much willing to do anything to make that happen.
That's helpful. Samantha, what do you think? Prospects for aligning federal policy with evidence and best practices?
I generally avoid predicting the future, but what I will say, and I think Elizabeth alluded to this in her comments, is, I think there's been a lot of great research to help inform improvements that could be made in how these questions are asked and what the federal guidelines or minimum standards are. In particular, as she noted, Census did a lot of research about the implications of adding a Middle Eastern, North African response category. And I think there have been, just across a wide array of stakeholders, growing calls to really begin to re-examine these federal standards to make sure that they are relevant for the population that is part of our country today. One thing that I think is going to be really key going forward is figuring out new ways to analyze and understand the experiences of people who are multiracial. We have seen the share of people who identify as multiracial grow significantly over time. And at some point, just putting them into a bucket marked other is not really going to be an option, because we're just going to lose the ability to understand anything meaningful from the data, and we're going to lose population size from the other groups. And I think there are some states that are experimenting with different ways to classify folks who identify as multiracial, not using mutually exclusive categories, for example, so counting people in all the categories that they identify with. Also putting people in the groups that are the least populous groups in the state. So there are different approaches that are being explored, but I think more research and understanding of what the implications are of those different approaches and how they shape our understanding of disparities, because how you group people is then going to impact what the measures of different health and healthcare measures look like by groups. So more research to understand that. And I think more research with the community and with individuals to understand, like, what are response options that resonate with them. You know, how do they feel as a multiracial person when they're presented with these questions? You know, I think one approach, the follow-up question is, you know, which group do you identify with most? I'm multiracial. When I was presented with that question, I can't answer that. So, you know, I think there are a lot of important topics to be focused on that are specific to this issue of our growing multiracial population.
Yeah, that's really helpful. I mean, we could get into a whole nother, as Niall said, ball of wax around like how people identify, then what impact that has actually have on their health and health status, right? Because we're here talking about the bottom line of trying to reduce health disparities and advance health equity, right? So I think there's a lot more food for thought there. I want to close by asking everyone to sort of consider a question and maybe share your answer here, which is just, you know, Niall, you talked about kind of deciding like what and when is good enough, and it does strike me like there's so much data here that we're talking about, data gaps, limitations, so many different entities trying to kind of collect it and like do something productive, constructive with it. You know, obviously with those guardrails around privacy and trust. But can you each share your thoughts on like how do we prevent sort of the lack of perfection? How do we prevent the perfect from being the enemy of the good here? Like how does the policy community prevent sort of the imperfections here from becoming an excuse for not doing what is possible to reduce health disparities and advance health equity? So I'll let you ponder that. Niall, I'm going to make you go first.
Yeah, so I'll start. I'll try and keep it brief. I think it's really hard, and also I think unfortunately it's human nature, and I think it particularly bedevils people who build health data collection systems, because I've literally seen it happen in person over the years. It's like, well, what if we added this? And what if we added this? And what if we added this? And then you end up with, you know, electronic health record systems with, you know, 50,000 discrete data elements and no insights that that come from it. You know, Elizabeth, you know, very well knows that I think we've finally gotten to a place where we're able to extract, you know, some useful insights to TMSIS, but it took a very, very, very long time. And arguably, there's a lot of extraneous stuff in there that was added with all good intentions that will never be used because it's just, you know, not, the fill rates are too low. So there's something about health data people that, like, you know, want to have it all, you know. I don't know if any of my other panelists agree or disagree with me.
Do you want me to go next? I
Sure,
mean,
go for it.
yeah. So I always go back and forth. I think that I always start with everyone needs to, or organizations, the policy community needs to have an honest assessment of their objectives or goals for achieving health equity, right? So I will define health equity as being achieved when everyone has a fair and just opportunity, the resources, the power, the agency to attain their full health potential. I mean, that's a CDC definition, that's a general definition. And so you want everyone to achieve optimal health, and you don't want anyone to be disadvantaged or encounter barriers to achieving that, their full health potential. And if that comes from providing them with those opportunities, those resources, I think thinking that way will make it a little bit less easy and not feel overwhelming, right? And I mean, I'm a data person and I like granularity and I want to see models and algorithms have all these features, but at the end of the day, it's actually about, you know, breaking all the systemic, structural, racial barriers to care or to health. And I think that's where sometimes we need to step back and say, you know, what is it that we're doing? Let's just provide the needed opportunities. I mean, and everyone may have a different need. Everyone may have different resources that they need to attain their full health potential.
Thank you. Elizabeth, Samantha, parting thoughts?
I kind of thought that was a perfect place to end. So
Awesome.
Good.
All right, a lot of ditto. Yeah, so an honest assessment of the true objective here, which is for everyone to achieve their full health potential, and you know, not letting ourselves get too far down a rabbit hole as it relates to that. Irene, Donko, Mullen with the last word there for sure. Thank you all so much for joining us. We're almost at the end of our 90 minutes. I think we could have gone for about 900 more, so thank you. Thanks to everybody who has joined us for this webinar today. Please stay tuned for the next Alliance, complete your survey, speaking of data, because we really do take a look, and we work for continuous quality improvement here at the Alliance. So please fill out that survey, and we will take all of your thoughts into serious consideration. And keep an eye on the Alliance website for details about future upcoming events. We will have our next one on the state of HIV/AIDS and applying lessons learned to current public health emergencies on Wednesday, October 12th at 1 p.m. Eastern. We'll have a recording of this webinar available on allhealthpolicy.org. Check us out, follow us on LinkedIn. Thank you so much to Samantha Artiga, Irene, Donko, Mullen, Elizabeth Lukanen, and Niall Brennan for joining us today, and again to Arnold Ventures for making today's program possible. Have a great afternoon, everybody. Thank you.